Hello, everyone. Welcome back to your anatomy class. Today, we're going to be taking a look at the muscles of the ventilation system or your respiratory system. So let's go ahead and take a look at what we have here, which will be largely regarding like what you use to breathe. So let's go ahead and start by taking a look at some muscles that some of which should sound familiar because we talked about them previously, but some of them are probably pretty new, which are kind of small and minute to some extent as well. So breathing is basically like the movement of air in and out of the body, but we do this in a little bit of a weird way. It's not what people think like when they think like use your lungs. It's actually muscles that are helping to either increase or decrease the volume inside of the thorax, which then relatively increases or decreases the pressure in the thorax, causing air to move in and out of the body. So you can see you have muscles that I'm sure you've heard of, like the diaphragm, and then ones we covered in lab, like external and internal intercostals, serratus posterior, superior, and inferior, and then a few more that are a little bit newer that we're going to be covering today. So let's go ahead and take a look at some mechanics of ventilation before we start talking about like the actual muscles and how they work. So when we talk about ventilation, once again, this is like the movement of air, and you have two major phases of that. Either air goes in or air goes out. So air goes in is going to be the inspiration, air goes out is going to be expiration. So basically, inspire is like inhale, expire is exhale. But when we talk about ventilation, like I was saying before, it's kind of due to like a change in pressure as well as a change in change in volume and then a change in pressure. So in order to do this though, you basically change the shape and volume of the thorax. So depending on whether the thorax is in an expanded form or whether it's in a compressed form, that is going to either increase the volume and decrease the pressure for inspiration, or if it's in a compressed form, it'll be decreasing the volume, increasing the pressure, which is going to cause expiration. So for inspiration, you're basically kind of working against like the natural form of the thorax. Like it kind of has like a shape. It is made mostly formed by bones as well as like skin and muscles surrounding it. But then you basically need to either increase the bottom size of it, as in like or elongate this cavity, or you can pull everything outward to increase the volume as well. So in this case, you mostly use like contraction of muscles to either increase the volume along the inferior aspect or lift up everything along the outside, like lifting up the ribs using muscles to increase the volume and decrease the pressure. So expiration, though, is kind of like the more natural side where like everything generally goes back to its normal shape, like everything kind of rebounds and has some recoil that goes to its normal type of formation, basically. So that's a little bit more passive in its form, but it also does have its own muscles that can help with further expiring as well. So like you can breathe very different volumes. So even like in inspiration and expiration, you'll be able to have like big and or like small breaths, like the one that you're probably doing now, the normal breathing. But then you also have the big breath, like that's using additional muscles and additional force that is going to cause those larger changes in volume and pressure. Now to take a look a bit about like how things are moving in the thorax, you can see that largely it's going to be the ribs, but you also do have the sternum that is going to be moving as well. So looking at the upper versus the lower ribs, like these can either elevate or depress, And depending on whether it's an upper rib or a lower rib, it does do things a little bit differently, but generally it is pretty similar. So you can think of the upper ribs more like a pump handle. So when these elevate and depress, like you can see that this part mostly is going to be moving rather than this part. But then along the inferior side of the ribs, the lower ribs, basically, like more so it moves like a bucket handle. So in this case, one side moves more than the other, but on this case, like kind of the whole thing moves to some extent. And you can see that when you have those movements, mostly like the movement is going to be along the anterior side, where you can see the changes either for the upper rib being a little bit more anterior and posterior, like the ribs extending outward towards the front, or for the lower ribs, they extend out a little bit more laterally. But also looking at like the front of the thorax, you can see that the sternum is able to move a bit as well. So the sternum is actually going to also be able to expand like with the ribs. So it is going to be able to expand out as well as change its angle slightly, like depending on whether it's going to angle like outward or inward. So likewise, that's going to help with increasing and decreasing the volume of thorax, and then relatively decreasing or increasing the pressure as well. So inspiration is basically where you have the ribs lift upwards, the sternum thrust outwards. That's going to increase the volume as much as you can. And then expiration is going to be where you have the ribs basically doing the opposite. Ribs go down, sternum goes down. So that is more of the kind of like elastic recoil of those structures going back to its normal shape. But something else that we can also see is that the diaphragm is going to be a very large part of this kind of process. So I do have something that I usually bring up to kind of like represent this a little bit. I mean, I think you probably can figure this out on your own, but just to kind of visualize it a little bit, if you look at these two things right here, these you can kind of consider like two general shapes of the diaphragm. Like you have one that's going to be curved like this, one that's a little less curved, or even like can be pretty flat as well. But real quick, the question I do want to ask here is, which of these two is a contracted, like diaphragm? And just knowing about muscles, when you have a contracted diaphragm, it's going to be a shorter muscle. So which of these is a shorter length? So hopefully you can kind of guess this, because I would like to think like, well, if I think about anything lengthwise, would I rather run this or this? And the question is, or like the answer to that is this one, because it's shorter. Like this is much straighter, it's much easier to like run. So that's the shorter one, meaning that this is the contracted one. And what that also means is that this shape is going to affect the volume and pressure inside of the thorax. So drawing in the rest of the thorax now, forgive my drawing, but you can kind of see what I'm getting at here. Depending on the shape of the diaphragm, you can see now that the thorax has more or less like kind of like room inside. So in this case, you have all the way from here to here, but for this one, you only have from here to here. So the contracted diaphragm is going to have a higher volume because there's more space, and lower pressure, meaning that this is going to be where you inspire. When you have like the air going into your lungs is when you have a lower pressure on the inside of your body, meaning that everything wants to flow inwards. But then if you have lower volume and higher pressure, that means that it's going to more push the air outward into the lower pressure of the environment. So basically, what I'm getting at here is contracted diaphragm means that you inspire. Relaxed diaphragm, the longer muscle, means that you expire. Oops, wanted to go back to there we go. So when the diaphragm descends, this is when it's contracted. So just to kind of elaborate a little bit on those mechanics of ventilation and the two like ribs. So upper ribs, this is where you have like the anterior aspect of the rib moving more than anything else. Like this is going to be allowing it to expand anteriorly and laterally. But then the bucket handle is mostly going to be upward and then also outward or laterally. So upward and laterally, this is going to be the bucket handle. This is going to be the pump handle. But both of them, regardless, help with, like, if they're moving in this way, elevating and then increasing the space inside of the thorax, allowing for additional breathing, basically. Now, when we talk about breathing, there's actually kind of like different types of breathing, mostly between quiet or forced breathing. So quiet breathing is the one that you do generally normally. Like this is what you're doing right now, I think, as long as you're like, I don't know, very stressed or very, I don't know if you've exercised or held your breath for a long time. But forced expiration and forced inspiration is where you can do basically your biggest breaths if you need to. So looking at these, like quiet inspiration is generally using only the diaphragm. Like quiet inspiration and expiration is generally where you have the diaphragm changing in shape and not even that much. Like the diaphragm, when relaxed, is pretty rounded, like this dome shape, but then it just needs to kind of like go down like 1.5 centimeters for it to increase the volume pretty substantially. Like the width of your thorax, the depth of your thorax. When you just depress this space just a little bit, that's basically enough for you to continue to live for the most part. Like all you need to do is like breathe about half a liter of air, like every breath, in order for you to continue to live in a relaxed environment. Like as long as you're not like putting your body under a lot of stress, undergoing a lot of exercise, your body doesn't need to really do that much breathing in order for you to continue to live. So like just about half a liter of air is all you need, and that is what you're going to be doing with quiet inspiration. Now, forced inspiration is where you start to take into account of all of those other things that are going to be affecting the volume of the thorax as well. So first of all, the diaphragm can descend a lot more. So it can contract a lot harder. And when you go from like a round shape, instead of being like just like this lower, it can actually go quite low and then flatten out. So instead of being that 1.5 centimeters, it can go either 6 to 10 centimeters downward to really flatten out and then also and like really increase the length or rather height of the thorax. So the right side can descend to around like T11, while the left side can descend to around D12. Like it goes basically to the bottom of the thorax where it's going to be originating or inserting or both. So like that's going to be the diaphragm, but you also do have like the ribs that are going to be helping to expand the thorax as well by elevating. So basically, kind of like where you looked at those, well, the bucket handle as well as the pump handle, both upper and lower ribs can expand outward so that the space can also increase, not just height wise, but laterally and anteriorly and posteriorly, oh, not anteriorly as well. So when you increase the volume of your thorax even more, that just allows you to breathe in or inspire even more as well. So basically, try taking a really big deep breath. Well, first, put your hands like on your ribs and then try taking a big breath. And you can feel your ribs expanding outward. Like that's what you're generally doing when you're taking like a big breath. like you are definitely using your diaphragm a lot. Don't like discount that. That's a big part of it, but your ribs increasing the volume is going to be really helpful as well. Now for expiration, this is kind of the opposite. I mean, for quiet expiration in this case, the ribs don't change too much because the ribs haven't moved that much, but the diaphragm is going to just basically go back to its normal relaxed shape. So when the diaphragm relaxes, the diaphragm becomes rounder and higher again. And what that means is that it's going to decrease the volume a little bit. But once again, it's not moving that much because it's quiet expiration, only moving about half a liter per breath. But for forced expiration, this is where you can actually start to use some additional muscles to continue to decrease the volume of the thorax. So while we've been talking about elevating the ribs, you can also depress the ribs as well. So depressing the ribs basically does exactly what you'd expect. It compresses the thorax so that it decreases the space even more. But something else that you can also do is use your abdominal muscles to push your abdominal organs or compress your abdominal organs, which can potentially push upwards into your thorax a little bit as well. And then furthermore, using your abdominal muscles, you can also kind of flex your vertebral column, which if you flex your vertebral column and bend forward, try breathing in really big while doing that, and it's a little bit more difficult. Your organs are being pressed up into your thorax, but then also you just do not have as much space to allow you to be able to, or it's not going to give you as much of an ability to allow you to increase your thorax anymore. So decreasing the volume of your thorax can be done with the diaphragm by relaxing, but you can also have the additive compression of the thorax using the ribs, which is going to be certain muscles, but then you can also push upwards even more using your abdominal muscles and organs by flexing your vertebral column, as well as compressing your abdominal organs as well. So, you can see that there's a lot of different changes that can happen for allowing you to inspire and expire. For the vertical axis, that's mostly the diaphragm. So the diaphragm is going to contract and move down for inspiration, relax and move up for expiration. But for the anterior and posterior axis, as well as medial and lateral axis, meaning going or expanding towards the front and expanding towards the sides, you would have the sternum that can move up and anteriorly for inspiration, as well as the ribs that can be elevated as well. And then furthermore, the opposite of trunk flexion, vertebral or flexion of the vertebral column, if you're more upright, you can also breathe in a little bit better as well. But then expiration is basically the opposite. When you flex the trunk, when you push your sternum downward using your rectus abdominis, and then when you also compress the abdominal organs into the thorax as well. But then you can also compress the ribs, or sorry, depress the ribs and compress the thorax using that way as well. Now, with that said, with kind of the mechanics of breathing kind of done, let's go ahead and take a look at some of the muscles that we have here. So when you look at inspiration, you can see that there's a lot of kind of big muscles that you probably are somewhat familiar with, but then you actually can use quite a few other ones as well for the forced inspiration, which is using anything that's attached to the ribs, basically. So some ones that are kind of big that I would like to bring up are scalene muscles, sternocleidomastoid, serratus muscles, even pectoralis and latissimus dorsi. So to take a look at this, or to take a look at our muscles, taking a look at diaphragm first, we have this big, broad muscle on the bottom of the thorax over here. This is going to be what you use for breathing. Like this muscle is going to be like what you use for quiet breathing, which is largely what you do for the most part of the day. Like you're not breathing really hard, like doing the forced inspiration, expiration all the time. The diaphragm is really the workhorse of the respiratory system. So regarding the diaphragm, we talked about a lot about how its shape changes and how that affects like its volume of the thorax. But just some specifics, it is going to be attached all the way along the bottom of the thorax, connecting to the sternum, the xiphoid process, connecting to the ribs, connecting to the ribs along the costal cartilages, and then all the way along like the bottom of the lower ribs. And then it's also going to be connected to the back of the thorax along the lumbar vertebrae. So this is where you're going to see that you have some attachment points that'll be kind of specific, which we'll be talking about in just a second. But as we were saying, like it is going to be used for inspiring and expiring depending on whether it's contracted or relaxed. And then one thing I should also note, although we'll talk about in just a sec, is that you have this, like you can see the muscle all along the edge over here, but then this part right in the middle, this is called the central tendon, which is going to have things going through it as well as like, well, basically the array of muscle fibers connecting to it. Now this muscle is innervated by a nerve that we've talked about previously, the phrenic nerve, C3, C4, C5. Now the diaphragm is going to have some specific connections, specifically kind of going around certain things. So this is where you're going to see kind of like some holes in the diaphragm, which is kind of weird to think about. But to start off with, if you look over here, you have the right and left crura. So the crusts or crura, these are going to be kind of like the extensions along like the lumbar vertebrae, which is going to be surrounding the median arcuate ligament, which is the median arcuate ligament, which is going to be surrounding the aorta. So median arcuate ligament is right in the middle. And then there's actually two more that are going to be along the sides over here. And you would have a medial and a lateral one respectively. So if you look closely, do you see these muscles back here? Do you know what they are? This one, the medial arcuate ligament, is going to be around the psoas major. This one, the lateral arcuate ligament, is around the quadratus lumborum. So it does have some specific parts that needs to surround certain things, but generally, like you can kind of find them pretty easily. Now there's one more thing that you can there's a few more things, I guess, that go through here, which are going to be big blood vessels. So like we were saying, you had those the crura that are going to be forming the median arcuate ligament. That is where you're going to have the aortic hiatus. So the aortic hiatus is going to be where you have the thoracic aorta traveling down through, and then after that, it's going to be considered abdominal aorta. So right along T12, that's where you'll have the aortic hiatus, where thoracic aorta turns into abdominal aorta. But then if you look closely, you also have a couple other big things here. The esophagus, which is going to travel through here from you need to have your food get down to your abdomen somehow. So it goes through the diaphragm, through the esophageal hiatus, which you can see right over here. So that is going to be where the esophagus travels through. And then one more opening while we're at it. If you look closely, you have the caval opening, which is going to be where you have the inferior vena cava going through it. So the caval opening or cava hiatus, this is where you have the inferior vena cava going through it near T8. All right, so next, let's go ahead and take a look at some additional muscles that are used for breathing, starting off with one that's a little bit less known or shown, which is the levitoris costarum. So levitoris costarum, like that's doing what it says. Like it's going to elevate or levate the costals. So this is going to be one that some of you actually might have seen earlier, kind of like underneath the erector spinae muscles. And that is going to be a little bit lateral to the vertebral column, but then you'll see it extend kind of like downward and laterally to connect to the ribs. So when these muscles contract, like the thing that I always like to kind of consider is like, which one is the more stable part and which part is the more mobile part? And for a rib, it's a little bit odd because like it has two stable parts. It either is stable along the sternum or it's stable along the vertebra. And in this case, it's stable along the vertebral side, meaning that it extends downward to the rib, meaning that it's going to pull it upward towards the stable portion. So you elevate and abduct the ribs, which is going to be helping you to inspire, basically. And as you can see, there's a lot of them here, meaning that you'll have spinal nerves T1 to T11, like the intercostal nerves going to them. Now, external intercostals, I mean, this is also relative to the ribs, but in this case, as its name suggests, it is more superficial or external. So the external intercostals you can see over here, and they are largely going to be more lateral. And if you look closely, like these are going to be along the lateral side, and they'll be kind of along the same axis as the levitoris costarum. So these are going to be going like, sorry, wrong way, up and laterally, which is the same thing as here, except, I don't know. The only thing is that you kind of need to follow the rib because it goes in the same angle, going like down, 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 down. And then as you travel like along the side of the abdomen, it continues to go down immediately. Like this is going to be the same angle as levitoris costarum, meaning that this also will elevate the ribs. And remember, like these are on the lateral side, so these are still kind of along like the stable port or like being stabilized along like the back more than anything. I know it does get a little bit towards the front, but these will help with elevating the ribs once again for inspiration. And then likewise, intercostal nerves T1 to T12 or T1 to T11 are going to be innervating them. Now, intercostal nerves are sorry, internal intercostals are going to be a little bit special in that they are actually going to be all along like the bottom of the ribs at an angle, which means that it is actually going to do two different things to the ribs. So at the very least, notice this part over here, like the anterior side or like these internal intercostals, which are deep to the external intercostals, are going to be more closely attached to their upper side at their anchoring point near the sternum. So the part that's going to be moving is the part that's back here, which is going to be like pulling it towards the anchoring point, which is elevating the ribs. But if they continue to go in this orientation along to the back of the thorax, it is actually going to start to depress the ribs because its anchoring point will be along the vertebra instead. So hold on, I have a little bit of an illustration for you. So forgive me, but this is what I'm trying to use to teach you. So external intercostals you can see over here. Just like the levitoris costarum, like it is going to be stabilized along the posterior side, and then it's going to insert down here and pull it upwards to elevate the rib. And then similarly, this portion right here of the internal intercostals, this portion is going to be stabilized along the anterior side at the sternum and pull them up in this direction. But now notice that along like the midway point of the thorax, these posterior fibers are now stabilized along the posterior sides of like the ribs. So what that means is that these posterior fibers are actually going to be stabilized down here and then pull these ribs downwards towards them. So at the very least, that's the way that I like to like think about it, to remember it at the very least. So the anterior chondral portions are going to be able to elevate the ribs, pulling them upwards towards the sternum. And then these fibers are going to be pulling them downwards towards the vertebra to depress the ribs. So yeah, I don't know. Hopefully this picture does justice for, I don't know, the concept, but that's basically how I think about internal intercostals at least. So moving on, we have the serratus posterior superior, which is also going to help with elevating the ribs. So the serratus posterior superior is going to help with elevating the ribs, and you'll be able to see that those are going to be attached over here at the vertebrae, and then they go down to the ribs and, kind of like everything else, pull them upwards to elevate the ribs. But in this case, because they're only up here, they are going to be innervated by spinal nerves T1 to T4. Now for expiration, you can see that you do still have like some muscles here, like the internal intercostals, but then you also have some that you might have not like completely expected, like abdominal muscles, which we talked about before. So we're going to mostly focus on like the respiratory, like focused ones, but just keep in mind that flexing the vertebral column as well as compressing the abdomen is also going to like be something that compresses the thorax and causes more pressure in the thorax to, well, basically cause expiration. So to start off with, there is even one more layer that's further deep than internal intercostals, which are called innermost intercostals. So you can see those internal intercostals, which are going to be like on the inside over here, but then you have the innermost intercostals, which are here and here. So these are more like, these are going to be more on the lateral sides of the ribs, and these are going to be helping with depressing the ribs. So this one, it's a little bit harder to like kind of like see the fiber orientations, but this one is going to help with depressing the ribs and basically maintaining like the shape and integrity of the rib cage. But you can see that they do extend kind of like upwards or like up and downwards. This is going to be intercostal nerves T1 to T11. So you have 3 layers of intercostals though. External, which is on the outside, internal, which is directly deep, and then innermost intercostals, kind of like the deepest along like the side of the rib cage. All right, next we have the transversus thoracis. Now this one is a little bit of a special one because it's kind of like forming like an array along like the sternum. This one is going to, like looking at it, be anchored at the sternum, but mostly go upwards towards the ribs. So being anchored at the sternum, this is going to pull the ribs downward and cause you to depress the ribs once again. So depress the ribs, cause an expiration, like the transversus thoracis. This is going to be for expiration or exhalation. And you can see that it's kind of broad. This is going to have intercostal nerves T1 to T8 innervating it. Now the subcostalis is going to be, once again, a little bit of a hard one to find, but this one is going to be somewhat deep as well. So this one you can see right over here, it's near the innermost intercostals, but this one is a little bit more narrow. So this is going to be right over here, kind of lateral to the transversus thoracis. So it would be like right over here. And this one, as it kind of like has been, well, actually, no. Oh, yeah. So this is going to be helping to depress the ribs. This is not near like the transversus thoracis. This is near the innermost intercostals. So this right over here, this is going to be like right along the edge of the innermost intercostals. This is helping to depress the ribs as well. So this is going to be, once again, intercostal nerves T1 to T11 and causing expiration. Now, serratus posterior inferior is going to be kind of the opposite of serratus posterior superior, where if you look closely, it's anchored at the vertebral column, but it goes upward towards the rib. So this is going to pull the ribs downward towards the vertebral column, causing, once again, expiration and depression of the ribs. And being down here, it's going to be innervated by spinal nerves T9 to T12. So to talk a little bit about pathology, just to talk a little bit about pathology. There's a couple of major kind of forms of this pathology, the first of which is restrictive lung dysfunction, meaning that it's just hard to get air into the lungs. Like the air or the lungs are going to be restricted in some way, either by like being affected by the thorax or the internal cavity of the thorax or the space inside of the pleura. So to take a look at this is basically just meaning that it's hard to expand the thorax and hard to get air inside. And a couple of those could just be due to effects on the thorax. Like if you have a rib fracture, it's gonna hurt if you start to try and pull on those ribs and try to expand them. So that rib fracture is gonna be hard, make it hard for you to inspire. So that's gonna be very difficult because it's gonna be super painful. But then you also have like kyphoscoliosis, which is an effect on like the vertebral column more than anything. But once again, that can be and have an effect on your ability to elevate the ribs or to elevate the ribs in an effective manner. And then another one that's kind of just related to the thorax in general is obesity, meaning that like if you have more adipose or fat tissue that is either on the outside or on the inside of the abdomen, this is going to make it difficult for you to depress the diaphragm or contract and flatten the diaphragm, or potentially even expand the thorax to some extent as well. But then one more that's a little bit special in this case is pneumothorax, which is where you have like pleural or like fluid that's going to be kind of filling some of that pleural space. And if you fill that space, that just means that your lungs have less ability to expand. So in that case, like it's not going to allow you to expand your lungs very well because there's just stuff already in there. So if it's hard for you to expand the lung or the thorax in general, that's going to make it difficult for you to get air in for inspiration. But the other thing that's a little bit tricky about or not tricky, but one thing that's kind of making it difficult to breathe, a pathology of ventilation, is obstructive lung dysfunction. So this is where you actually obstruct the airways in this case, which we'll talk more about when we get to the respiratory system. But if you have something blocking those airways, that just means that air is not going to be able to travel through very well. So a couple that you probably have heard of, asthma one. Like this means that you have like the airways kind of like being blocked due to inflammation as well as constriction of those airways using smooth muscles of the bronchioles and bronchi. So if it narrows those airways, it's going to make it hard for air to travel through it. Cystic fibrosis is another one that's kind of in the similar vein where, in this case, you have excessive amounts of mucus blocking the airways instead, but once again, smaller airways, harder for air to go through. But the one that's a little bit different is emphysema, which is where you can see like a comparison between healthy alveoli and then emphysema alveoli. Basically, these alveoli no longer have the ability to kind of like constrict and expand again. It basically is kind of like scar tissue at this point. Like it has broken the alveolar wall so that it cannot, or it's become like inflexible. So without that elasticity, there's actually a lower ability to exhale in this case. Like if you cannot compress or if you cannot collapse the alveoli, like that's going to make it harder for you to breathe out all of the air. So there could be air kind of like held in these like pockets inside of like these damaged alveoli, which is not good. So all of these things like make it hard for you to move the air inside of the lungs, which is an obstructive lung dysfunction. So with that said, though, that's about it for today. I think we'll talk about the respiratory system and the digestive system soon, but we'll wait on that for later. So thanks for listening. Good luck with your studying, and I'll see you all next time.